I'd like to introduce Kurt Sear, who's going to lead you through this great conversation today.
Thank you.
Thanks.
Let's start out with figuring out who you are. So how many pharmacy students do we have? Quite a few. PA? Great. MSNA? Nursing?
Nurses.
Dental hygiene? I don't see any dental students. Dental students? No. Oh, there's one. Yeah. So,
Occupational therapy.
oh, physical therapy or OT or PT? Anyone I didn't mention? Social work? Great. So what we're going to try to do is keep things interesting. I'm going to be asking you a lot of questions. We'll be passing around the mic and get you to talk. And then we also have 2 interactive cases where we'll stop and have you work on them. And the whole idea behind interprofessional education is more than one group of students interacting with each other. So make sure that when you do the cases that you have a good representation. I know it's easy to just stay with your buddies from the same program, but that defeats the whole purpose of interprofessional education. So a little bit about me. I started as the founding associate dean in the College of Pharmacy and then jumped ship to College of Dental Medicine. When I was associate dean, I was helping them design the basic science curriculum. And I teach the physiology, pathophysiology, and pharmacology. We basically move through the systems. When I first came here as an associate dean, I got a phone call from a company called Healthcare Litigation in Massachusetts. They act as a repository for expert witnesses, and they were looking for a pharmacologist, and I sort of checked all the boxes. And I had done a couple of cases locally prior to that, and it was interesting for me. So I agreed to do it. So I've done probably 3 dozen cases over the last 8 years. So I've done a lot of different things in my career, teaching and administration, and worked as a pharmacist and scientist, and my PhD is in pharmacology. This is the only part of my job that I sort of fell into, that I didn't actively pursue this. Somebody reached out to me, but I like to continue to do it for these reasons. And I'm getting away from reading slides to students. I can assume you can all read, so as I talk, you can read. But basically, I'm there to help patients. I'm there to help try to make the system better. And personally, I like it because I always learn something new with each case. The experience I've had with the 2 dozen cases, it's remarkable. I basically get a phone call if the case has anything to do with drugs. So murder cases, and that was one of the first cases I did, was an appeal murder case where a woman had broken up with a guy, started dating another guy, talked the new guy into going back to the old guy's house to get her stuff. Old boyfriend lets him in, takes a gun out of the stove and shoots him dead. He then goes to jail. He then gets a public defender who files an appeal. I was hired by the lawyer who initially defended him, and they found a retired pathologist in New Hampshire who made the argument that because THC and Valium, and he wasn't prescribed the Valium, were in the guy's system, that there's a very small percentage of people who take both THC and Valium, and it makes them aggressive. So I wrote an opinion that said, no, Valium hyperpolarizes cells through a chloride channel, and THC hyperpolarizes cells via a potassium channel, and hyperpolarization do not equal depolarization. That in the majority of the patients, they're going to be tired. You know, often I had a pharmacist friend who wanted to know what, he had never taken Valium, wanted to know what it was like, and he, on a Saturday when he had nothing to do, took one. Obviously I don't recommend this. And he described it as becoming one with the furniture. So obviously this is not a combination of 2 drugs that's going to make somebody aggressive. And the case was thrown out. And why I bring it up, I only take cases that I believe in. I don't think that retired pathologists really believe the opinion. And you see that out there. Expert witnesses that are hired guns that if you pay them enough money, they will either skew their opinion or find something that will reinforce the case that the lawyer is trying to try. I've had several cases, probably 10% of the cases that come across my desk that I don't take. And I say, you don't want me, because if you put me on the witness stand, I'm more likely going to cause more harm to your client than good. Often when I say that, they still retain me, and what I'm doing then is not providing an expert opinion or deposition or testify in court. I'm educating the lawyers that are trying the case and providing either information or questions that they will then ask the people that they're deposing, or if it gets to trial, the way they'll try the case. So it's more of an education of the lawyers, and it's tremendous, especially the good lawyers. It's amazing. They'll take a case that they have no background whatsoever in and become experts, because that trial environment is very intimidating. Out of the 36 cases that I've done, I think only 6 or 7 have reached the deposition point, which is very stressful. But that's just you and the 2 lawyers with a court reporter, and they're firing questions at you. Oftentimes that can be stressful because it's a fishing expedition, or they're trying to do the whole poke the bear thing to see what your reaction's going to be. I did a 2-hour deposition, and the opposing counsel hardly ever talked about the case. He had me walk through my whole CV from like high school to now, and I think he said at least a half a dozen times, he asked me whether I was a medical doctor or not. And again, just try to see what I would be like once I got to the point of testifying in court. I've only had to testify in 4 cases, and 2 of those, well, actually one was very brief. One was probably a half an hour. Another one was 1 hour and 45 minutes, one of the cases we'll talk about today, and another one was 2 hours and 45 minutes being on the witness stand, just being grilled. It was brutal. And that's why you're paid a considerable amount of money. I always go into that thinking, wow, I'm paid way too much. And then I come out of testifying and say, wow, I'm paid way too little to go through that. So you have to, if you're thinking about this type of thing, you have to anticipate that if you're going to be an expert witness, you can't just sort of do the reading and writing and emails and that type of thing. You have to anticipate that, yes, you will carry this case to a deposition and you will have to testify in court. So what have I learned over the last 8 years? Certainly, it's the healthcare system is, in some respects, really broken. And that's what we're looking at to do today, and we'll talk about the learning objectives. I think the biggest thing that can fix things, based upon my experience doing this, is communication. That all of you in the room have to get out of those silos and start talking to each other. First and foremost, to improve patient care outcomes, but then secondly, you don't want bad things to happen to your patient. Not only is it the problem with the litigation and possible liability insurance and all the other things associated with it, you don't want to be that person where it could have been a preventable error, someone gets hurt or dies, and then you have to carry that with you for the rest of your life. I mean, some of these cases are devastating, and you're reading the medical records and autopsy reports, and it's, can be very sad and depressing. And I always wonder that. Thankfully, as a pharmacist, I've never had a big mistake, and I wonder how people cope with that for the rest of their career. So we'll talk about, in the beginning, some of the repercussions financially on the healthcare system, and certainly your liability insurance and things like that will go up if you have things in your record that mistakes that have been made. We'll talk a little bit about liability and malpractice, some definitions, try to identify the problems in the healthcare system, and a number of the cases involved when a patient is transitioning from one environment or one provider to another provider. And hopefully, through communication and electronic medical records, a lot of that will go away. And through the Affordable Care Act, part of it, they went around and offered incentives to providers to switch over to digital electronic medical records. And if you're working in a practice, I would really suggest that you move in that direction. It could be brutal with the transition. I have a friend who's an optometrist. They had a room of like this size full of all the paper records. It's in Lewis and Auburn. And it took a good year or two for them to convert over. But once you make that transition, it's night and day difference in the services you can provide. I could show you, actually I can't because obviously the HIPAA, but if I were able to show you some of these medical records, one of the cases that I'll talk about today, it was brutal trying to read it. I mean, it looked like somebody took a chicken and had him step on ink and run across the page. I mean, I'm in the healthcare for the last 30 years. It was really difficult for me to even ascertain the most important information from that record. So there was a paper published that talked about medical errors, and they reviewed articles published between 2008 and 2011 and estimated that medical errors in general, I'll talk about in the next slide, specifically medication errors, but medical errors in general resulted in 200 to 400,000 deaths per year. And it was 10 to 20 times that for people who had serious harm. So the numbers are staggering. And if you look at the cost to healthcare, it's incredible. And if this data is correct, this would make medical errors the third leading cause of death in the United States, behind heart disease and cancer, and above chronic respiratory diseases. Medication in general, this study talked about occur in 3.8 million inpatient admissions and 3.3 million outpatient, and they estimated 7,000 deaths a year in the US are from preventable medication errors. And just think of how many are a situation where someone is harmed but does not die, but the harm that can be caused can be permanent damage, and we'll talk about that with some of the cases that I've had. And you look at the cost, a lot of studies estimate that the cost to the healthcare system for medication errors exceeds the cost of the actual medications. So what did they propose? And some of the things that we'll talk about today, the first and foremost is that communication among different healthcare providers, and including pharmacists. Obviously I'm skewed because I am a licensed pharmacist, but including pharmacists on medical rounds, adding them to intensive care teams, having follow-up, either what we call medication therapy management, which is more intensive, or medication adherence, just making sure that patients take the medications that they're prescribed. I read one study that it was a closed loop where they had electronic prescription, the ability to e-prescribe, that it goes right from the provider's office to the pharmacy, and then from there to the insurance company to make sure it was paid for and that the patient picked it up. In that study, 1/4 of the prescriptions for chronic medications were not picked up. For whatever reason, the patient's cost or side effects, or just decided they didn't want it. 1 out of every 4. So if you're generating prescriptions, you should make a concerted effort to make sure that those prescriptions are not only being taken, but taken correctly. Another 12% of those chronic medications were picked up once, but never refilled again. So now you're talking about 1/3 of the medications, prescription orders, are never filled beyond that first prescription. And you run into a lot of medication errors as a result of that, because a patient is only taking it intermittently, say 50% of the time, and they're going back to the doctor's office and saying, I'm taking my prescription regularly. And they're not, and the doctor assumes that they're taking the prescription and then increases the dose. And if they continue to take it 50% of the time, something bad may not occur, but often what happens is that patient is then brought to an ER or admitted to the hospital, and they're given the administration. There, the administration takes place. If it's 3 times a day, someone every 8 hours goes in there and makes sure they take it. they now go from taking it intermittently to taking it regularly. They reach a toxic dose or an adverse effect takes place because they're not. So how do you fix that? Any suggestions? You're a prescriber. We have people on the Bedford campus. They're going to be prescribers. We have people here, the PAs are going to be prescribers. How do you make sure that that's taking place?
Medication diaries or having the patients bring in their bottles to visits.
So medication diaries and having them bring in their bottles. And that's a great thing. If you're dealing with medication, and I suggest it to the dental students because they take a complete list. And you're not doing that they would then date. Patients they're taking, but then how do you make sure that they're actually taking it? How do we make sure that they're actually taking it?
CVS now is making bottle caps that actually have counters on them. So they're actually just being rolled out. It's a new thing. I work for CVS as an intern, and we just got the paperwork on it last weekend. But they're caps that every time it's opened, it will say there's one less tablet in it. So if they
That's
take,
great. So medication counters, that the new technology that's coming out. Any other suggestions?
Making sure they feel comfortable being honest with their
Oh, go ahead.
trying to make them feel comfortable being honest with you about whether or not they're taking it.
Absolutely. It's a very important component of counseling. And we did a study with a couple of pharmacy students. I had them as fourth-year pharmacy students that were in the oral health clinic, and we did a medication adherence study. And that's one of the questions that we would ask. And we had a survey, and we then included a component that might be hard to do in practice, but if you develop that relationship with pharmacists in a pharmacy, you can look at the prescription record. So this comes up all the time in the cases that I'm doing, and we'll talk about it in one of the interactive cases. And what we did in that study is we got 2 years worth of prescription records from the pharmacy. And then we were able to actually calculate. We threw out the first month and the last month, and we took 22 months, and we just looked at how many refills they got over those 2 years and divided by the 22 to come up with. And you would be surprised. There, some of the patients were only taking their medication 30, 40, 50% of the time. E-prescribing, we talked about, decreases errors, and also the VA actually piloted the program first, and a lot of hospitals do this now. The patient has a barcode, the prescription has a barcode. Before the nurse administers it, they have to scan the prescription and scan the patient. And first, you're making sure the right patient got the right medication, but you're also making sure that they got it in a proper window. So if it's outside that window, it will produce an error that they then have to correct before they can administer that medication. So again, I won't read you the slides, but criminal liability is obviously for criminal laws as opposed to civil liability, and this is what is involved, civil liability in the malpractice cases that I do. Product liability, I did have one case that involved that, where you had potentially a defective product. Negligence is misconduct or lack of ordinary skills. So what we talk about is that breach of duty or a breach in the standard or practice. And that's where expert witnesses come in. So a mistake is made, an expert witness is hired, and I've had cases that are both involved both the plaintiff and the defendant. So if I'm hired by the plaintiff's lawyer, I'm making the argument that the standard or practice was breached. If I'm hired by the defendant lawyer, I'm defending that healthcare professional and saying, no, the standard of practice was followed. And that's what it often comes down to. There's that imperfect system. It's human beings that are involved in the trial. It's either, in the civil cases, a judge The plaintiff can decide whether a judge will render the decision or whether a jury will. And then you have expert witnesses on both sides that then testify, and if it's a jury or a judge, they're making the decision of which expert witness they believe, and then that often determines the verdict. We'll talk a little bit about that in the second case that we'll do. And again, the duty that you have. So for a pharmacist, it's pretty simple, right? You have to fill that patient prescription correctly, and then since 1990, you also have to counsel the patient. So you want to make sure in your profession you understand what your duty is and that you're fulfilling that duty. And so the breach of duty can be two things, nonfeasance or malfeasance. Nonfeasance is you just didn't perform that duty. Malfeasance is that you didn't perform that duty well. And then for most states, you have to prove harm to the patient. I hope he was joking, but the lawyer that runs the consulting business that I work for said, no, you misfill a prescription, that's worth at least $10,000. Well, that's not the way it's supposed to be. If I misfill your prescription and you walk out to the parking lot and you notice that, or get home and you notice it's the wrong medication, and you bring it back, you can't sue me because there was no harm done. Or if you take that medication and it's, a antibiotic instead of another, and no physical harm came to you, then in theory you would not be able to sue me for damages. Some more lawyers would then argue the whole pain and suffering thing, or psychological, but in theory that's not supposed to take place. What may be hard to tease out is if that person ingests the medication, the wrong medication, and an adverse effect takes place, and that person has a whole list of congestive heart failure and diabetes and psychological problems. How do you tease apart that ingestion of that wrong medication is what actually produced the side effect, and that it was not due to an underlying condition? So here's your first opportunity for interactive case. I'll introduce it. It was a 47-year-old man that presented to the ER after an ATV accident and with loss of consciousness and a head laceration. So he didn't crack his skull, but he had an avulsion. You know what avulsion is? You got a big flap of skin that they then had to put back and sew up. And he did have, with a CT scan, he did have a subarachnoid hemorrhage. He was bleeding a little bit into his brain. And 4 days later, they decided that he was back eating regularly and the pain was managed and that they could discharge him. So prior to the discharge, there's evidence in the literature that if you give phenytoin, an anticonvulsant, you decrease the chance that they will have a seizure after the trauma. It doesn't decrease the morbidity, that somebody would die from that. The mortality it doesn't decrease, but it does decrease the obvious associated morbidity. So it doesn't prevent you from dying if you do have a seizure, but it does decrease the number of seizures that you would potentially have. So in the literature looking at this, because that's what I do as an expert witness, I go into the guidelines because I'm often, I'm not an ER trauma physician or pharmacist, so I have to go in and educate myself. And in the guidelines, they talk about giving a loading dose. Well, the first red flag is most of the time this loading dose is given by IV in the hospital. They load them up with the phenytoin to get a blood concentration, and then they send them home with a maintenance dose to keep that blood concentration for 7 to 10 days is the normal duration. Well, this they decided to give 50 milligram chewable tablets, and they chose this dose so that they could give him many of them over a short time period to get him up to that dose. So the directions were 8 tablets every 2 hours for 4 doses, and a total of 96 tablets. This was the second red flag. So get out your little calculators. How many tablets should they give if it's 8 tablets every 2 hours for 4 doses? What's 8 times 4? 32. Why did they dispense 96 tablets? Then the maintenance dose is the 300 milligram capsule that's taken by mouth every night for 7 days. The first dose was given that morning of the discharge, but it was not noted in the discharge notes by the nurse. And there was definitely record that she did counsel because 2 other medications had been given prior to discharge, and she made a note of that on the discharge notes. So the actual number of tablets shouldn't have been 32. It should have only been enough for 3 doses, 24 tablets. The pharmacist dispensed it without making a call. And the pharmacy was inside the hospital, and they had access to the records that first dose had been administered. And the pharmacist did not counsel the patient, but she did ask if the patient had any questions regarding the prescriptions. The patient's wife happened to be a registered nurse. She misinterpreted the directions as take 8 tablets every 2 hours for 4 days. So she continued to give that to him. The maintenance dose was also given the first day, and the patient should have been counseled by both the prescriber and the pharmacist that maintenance dose shouldn't have been given the first day, because they're giving the loading dose, and then the maintenance dose should have been started on the second day. So the patient ingested 4,000 milligrams because they had the bottle left. They basically had taken, I think, 80 out of the 96 tablets. Yeah, 80. And at least 600 of the 300 milligrams. So he started to have blurred vision, loss of control of bodily movements, dysarthria, unclear articulation of the speech. He was difficulty walking, so the wife brings him back to the ER. They take blood levels over the next, I think he was in the hospital for another 3 or 4 or 5 days. The peak was 48 micrograms per milliliter. At discharge, it was still at 43 because it has a pretty long half-life. And toxic symptoms start to occur after 20. Yeah, so it was 5 days later. He also showed low white blood cell count and was diagnosed with drug-induced liver injury and suspected hepatitis due to the toxicity. So if you could get together in small groups and let's take like 5 minutes to talk about your acting as the jury. And if you need more time, I'll give you more time because I think this is the most important part where you start to discuss this. So make sure you have different occupations represented and write those down on the sheet because I want to collect them and see how people interact. Prescribers should have to counsel for the medications that they order. So it wasn't clear in the record whether that took place, right? Because it could have taken place from a prescriber just saying it orally and it was never entered into the, but that is the standard of practice now. As a prescriber, you're supposed to talk about the medication, how it works, the directions, any side effects the patient should be, just as a pharmacist. And the whole excuse, well, I just prescribe it and the pharmacist will take care of that. That doesn't work, because then they're going to bring in a prescriber who's going to say, no, every single prescription that I dispense, I counsel thoroughly. How many of you thought the discharge nurse was liable? And again,
So I think, again, just part of the breakdown there, I think she should have also had some discharge counseling as well.
and that was pretty clear, because there I saw the discharge notes, and she had handwritten that she said that, I can't remember the other 2 medications, that she had counseled the patient that he had already taken those medications and that he should wait before taking the next dose. And certainly, with these complicated directions, how many think the pharmacist was liable? I'm a pharmacist and I agree with you. The pharmacist should have been counseling. You're obligated to counsel every new prescription that has a new number. Even if it's been a heart medication that the person's been on for 10 years, you're obligated with a new prescription order to counsel that patient. A lot of people have a technician, and some of the regulations have changed to allow that because you're in a busy store filling hundreds of prescriptions. And someone comes down, the technician asks you, do you have any questions for the pharmacist? And in a lot of states, that's sufficient. But I would make the argument, especially with a complicated medication like this isn't a normal maintenance dose with very complicated directions. They should have caught the error in the quantity. I would hope that I would catch the error in the quantity. And to counsel them and to again talk about adverse effects and things of that nature. How about the hospital? How many thought that the hospital was? And why did you think the hospital was liable?
We thought that they could have had a better protocol to make sure that all of those providers were communicating to catch that mistake somewhere along.
Yeah, so obviously one of the benefits of having a case like this, and it's hard to say benefits, of a hospital paying out money, hopefully they're going to sit up and pay attention to the protocols that they have in place and then implement new things. And this is why it's really important to document errors. You know, natural tendency for people is to say, oh, geez, I made an error. I don't want to, if I stick my head up and talk about this error, I'm going to get whacked. You don't want to have that attitude. And a lot of employers now, especially in pharmacies, if you do not report a medication error, you can be fired for that. That's a fireable offense. So you want to make sure you document it, if for the sole reason that those should then go to a central place, because it's no good to just document the errors. Someone then has to analyze that and implement procedures that are going to fix those errors. How about the last one? How many of you thought the patient's spouse, because she was a registered nurse and she misinterpreted the directions? Anybody? No, you sort of have to make that disconnect. You can't then assume that she's going to, it did come up in talking about it, in preparing the opinion with the lawyer and stuff, but you can't make that disconnect because she wasn't performing the function of her profession, taking care of somebody in her family.
Kurt, we have a comment from Biddeford. They agree that most everyone is at fault, and they're coming in at $3 million and a new liver settlement.
$3 million and a new liver. Okay, the actual settlement was for $130,000, and the other details I didn't share with you: the patient wasn't wearing a helmet, he was intoxicated, and there was excessive speed. Does this change your opinion at all? No, it shouldn't. Even though the guy's an idiot for doing all of what he did, you can't penalize him for being an idiot because the two things are completely different. The accident and the prescription have nothing to do with each other than the fact that the prescription was given as a consequence of the accident. So I've had, like I said, 36 cases. Probably half of those are due to errors with opiates, in part because I did 2 postdoctoral fellowships that were sponsored by the National Institute of Drug Abuse, one in New York and one in Seattle, and they were both labs that studied opiates. But it's unbelievable the number of cases that take place. This one was 19-year-old with sickle cell anemia, and you have to remember with sickle cell anemia, when they have a sickling attack, the normal biconcave disc that erythrocytes should be that tumble through capillaries and keep going, now sickle and stick to each other and then stick in capillaries. So when they have a crisis, there's diffuse pain all over their body, particularly in areas where you have a lot of capillary beds. So he showed up with, at the emergency room at 1:45 a.m. and the only thing that was remarkable was the oxygen saturation was a little low. Normally you'd want that between 95 and 100. And he did have some pallor of the mucous membranes and skin, so to suggest again he's going through a sickling crisis. So they put in oxygen to bring his oxygen saturation up, and that happened pretty quickly. Then he went back up to like 98%. They gave him Vicodin because they couldn't immediately get a vein, but they give him the oral tablets, and then they brought in a phlebotomist who did it right away. What's the problem there? Those oral tablets are going to take, depending upon food in his stomach, half an hour, 45 minutes to an hour to work. Then they gave him morphine sulfate, initial 5 milligram injection at 2:52, and then 10 milligram injections at 3 a.m., 3:10, 3:20, 3:30, 3:45, 3:55, and 4:05. 75 milligrams over 73 minutes. He was awakened from sleep and re-examined at 5:30 a.m. Why 5:30 a.m.? It seems like a weird time, right? That was the shift change in the hospital. And they discharged him. And the girlfriend literally carries him out to the car, goes home, he goes to sleep, she checks on him at 5 p.m., 12 hours later. She can't get him to wake up, calls the EMTs, his pulse is down to 54, his oxygen saturation's only at 48. You start to crash after, below 80. He was intubated, transported, and then pronounced dead at 6 p.m. Autopsy was performed, and death was deemed natural secondary to vascular occlusion as a consequence of the sickle cell disease. He had a lot of pulmonary emboli. But the toxicology, the morphine levels were sufficient enough to produce anesthesia and potentially toxic. His pain index was 9 out of 10 at 3:45 a.m. and down to 3 out of 10, and was still given 2 more injections. And like I said, they were initially unable to find that vein, and that's why they gave him the Vicodin. And he did have a history of respiratory depression after opiate administration, but to be fair, the hospital was a different hospital and they didn't have those records. So how do you think the morphine contributed to his death? So opiates cause respiratory depression. That was the beginning of my opinion. And then what's the next in the cascade? You'd have to know something about sickle cell disease. Right, due to the hypoxia, the cells sickle more. So that was what I stated, and I'll talk about that in the next slide. That's what I stated in my opinion, that he was given too much morphine, respiratory depression, and when you're given that much morphine to induce anesthesia, you lose that ability to wake up from that air hunger, from the hypoxia, which would then trigger you to breathe more. So then from the hypoxia, it sickled more, the cells sickled more, and then those emboli stuck in his lungs, and then that's what killed him. How do you think this could have been prevented? Go ahead.
A more detailed patient history?
More detailed patient history to know that he had respiratory depression from previous opioid administration. Potentially, but obviously the guy's sickling in a lot of pain, so you don't know if you're going to get a good history there.
Not giving him the extra doses when he was in 3 out of 10 pain.
Not giving the
extra the doses after 3:45 a.m.
Yeah, so pain index. So he was 9 out of 10. If they give him all the opiates in the planet, they're going to put him out. But if he's remaining conscious, what do you think a good pain index is if they start out at 9? Are you going to get down to 1 or 0? Especially not in an acute condition. I think the best that you're going to do is somewhere around 3, 4, 5. So once you reach that level of analgesia, you should stop administering it. And it speaks to what's the big red flag here? Maybe we should jump back.
They shouldn't have discharged him.
That's another big red flag, kicking him out at 5:30. What's the big red flag on this?
Oh, the Vicodin. The oral Vicodin.
The oral Vicodin, that's a little red flag comparison. What's the giant red flag? 75 milligrams is 73 minutes. What's the normal dose administration of morphine? I couldn't find anything that suggested that you give it quicker than every 3 hours, and the normal administration's every 4 hours. So you should be getting one 10 milligram injection, especially in a patient. It's different if the person is tolerant, and you might have to give a bigger injection for that. But giving this amount, I mean, look at how quickly they were giving it. It was only 8 minutes between the first 2 injections, only 10 minutes between the third and the second and the third injections. Way too much opiates, way too quickly.
Did they give an explanation as to that dosing schedule? Like the people, did they explain that dosing schedule?
Did they give an explanation for the dosing schedule? No.
No.
No, and that's unfortunate, is that once the lawyer shows up, everybody stops talking, because that's what the lawyers are telling them to do. And to me, that's, you know, super harmful. It doesn't get you to where you need to be, and it's kind of short-sighted because it's going to come out eventually once this court keeps progressing and you take depositions, and then people have to tell the truth. And so this was my explanation that we just talked about. And then the possible solutions, which goes back to the discharge at 5:30. Why did they discharge him? If they had just kept him in the hospital and monitored his oxygen saturation and respiration rate, they would have been able to go in there with the opiate antagonist naloxone. If he went into respiratory depression, administered the naloxone and reversed the opiates, and he would have survived. You know, there's no good explanation for why they. So that's what you want to pay attention to. Somebody is given very potent analgesia or anesthetics. You need to monitor those people until those effects reverse, or at least you feel good that somebody's going to be watching them, or that the dosage you gave was appropriate, because obviously, especially minor procedures, you don't want to keep a whole army of people in your office until the effects go away. But you have to feel confident that they're not going to go home and go to sleep and nobody's going to monitor them and undergo respiratory depression. So here's a second interactive case. 43-year-old female had an accident. She was hit by a construction truck, not once but twice, spun around. She had soft tissue injury, and she was treated for that. Then they were coming up with a dollar value. It's called a life care plan, and then if any of you are interested, it's something that you can, doesn't matter what the profession is, most of the time it's nurses, but you can take courses to be certified as a life care planner. And what you do is you go through their records, and then you meet with the different providers and you come up with a dollar value per year. Because the insurance companies don't want to pay for the cost of this person every single year. So then they go to an actuarial chart and they say, okay, she's going to live another 40 years. They get the dollar value for the what it's going to cost to treat her per year, and they multiply that times 40. So I was hired by the insurance company to contest the life care plan. Her pain meds were fentanyl patch, 100 microgram every 3 days, Opana, which is oxymorphone, extended release 60 milligrams twice a day, the immediate release 10 milligrams, 4 to 6 tablets every 4 to 6 hours, 672 tablets per month. And there were 2 dosage increases that one went from 120 of that immediate release up to 240, and then from 240 to 672. So take another quick 5 minutes. Do healthcare professionals have a legal obligation to assess the efficacy of patients' pain medication therapy and make recommendations to the prescribing physician? It's on the backside, and there's a couple of other questions. History, because obviously if you don't know or they don't share it with you, you're not expected to know something that you don't know. But if you're taking a medication history, or the standard or practice in your profession is to take a medication history and you don't take one, or you do take it and you see this, are you obligated at all to do something about it? And obviously that's a tricky question because we're dealing with lots of different professions. But as a healthcare professional, what do you think? Do you just say, he's the prescriber and he knows what he's doing? To start with, is there any upper limit for the administration of opiates, maximum doses?
Yes.
No. No, because of tolerance, the patient can escalate up to huge doses. And you do see this with, we're talking about chronic pain versus pain associated with cancer. So that's a different story. If it's non-terminal chronic pain, there are different guidelines. And there are guidelines that just came out with the CDC in 2016. So in theory, pharmacologically, there's no upper limit. But it has to do with how much the patient has already taken before, how tolerant they are. And then also, as you escalate the dose, is it working? Because if it's not working, the guidelines now say either keep them at the dose that they're at and other methods, or wean them down and use other methods. Physical therapy, management of the stress associated with the pain, breathing exercises, dependent upon the mobility of the patient, everything from acupuncture to yoga to cognitive behavioral therapy. There's lots of other things that are now recommended to help that patient manage pain. And the current guidelines state you do not just keep escalating. And you start with small incremental doses and you see if it's working and give it adequate time, anywhere from, dependent upon the thought of patient variability, from 3 days to a week or 2 weeks to see if that increase in the dose is going to work.
I do have a question from Biddeford. There's not a legal limit to how much you can prescribe in Maine?
There's not a...
Is there a legal limit to how much you can prescribe in Maine?
Yes, that's a good point. The prescription monitoring program just changed laws, and now it's based on the morphine milliequivalents per day, and you really need to go in and read those, and there's a little gray area right now because they're implementing it. But over a certain milligram, and I give talks on this, CE talks, and I'll make sure that I'm going to be giving one to the dental community that is distributed, that I go over the PMP law and the new 2016 guidelines on the CDC. But it's based upon morphine milligram equivalents per day, and as part of that CE, I actually have people calculate, and you calculate hers, it's like 1,200, and the new limits are 100 and 300, so way over the amounts that are now legal in the state of Maine, and a lot of states are moving in that direction because of this opioid epidemic. I mean, it's unbelievable what's taking place. I just read an article in a dental journal, because I'm trying to catch up in the dental world. The average number of tablets, narcotic tablets, opiates that are given for oral surgery, like when somebody has their wisdom teeth removed, is 30. The average number of tablets ingested is 17. So there's 13 times every prescription prescribed by every oral surgeon. They estimate that's 100 million tablets of opiates that are not ingested per year. And that's where the majority of people that are abusing medications don't get it from drug dealers. They get it from family and friends, relatives who may have it, that they steal it and that type of stuff.
And also, it's a federal offense, yes?
And it's a federal offense to give medications to somebody who does not have a prescription. And obviously that takes place every time, but you do not want to be doing that. That, okay, I've got some leftover opiate tablets from my oral surgery and my buddy's in pain because he just sprained an ankle, I'll give him my extra. That's a federal offense. So what are potential solutions for this type of activity and also for diversion? Somebody who's on chronic pain meds should have a pain therapy contract that stipulates that the patient will be denied service if there's evidence of abuse or diversion, and they'll also often designate a single prescriber and a single pharmacy. But in this case, it was a single prescriber and a single pharmacy. to avoid that sort of doctor shopping and pharmacy shopping where they're getting multiple medications from multiple prescribers and then filling them at multiple different pharmacies. And to review patient records and third-party reimbursement records to monitor the abuse or diversion, regular drug screens to make sure they're only taking the prescribed medications. I've had cases where patients have been denied service because they were on opiates, and then they did a drug screen and found THC and Valium and other recreational drugs. Small incremental increases, so 10 to 25% increase in the dose with regular physical assessment and utilization of a pain index. Again, there's a lot of patient variability, but 2 to 4 weeks, if it's not working, you don't just keep escalating the dose. And then again, the alternative therapies. So what I did in this case was I plotted out her pain indices. So every time she had a visit, they asked her, what is your pain index today? What was the worst pain index since the last time we saw you, and the best pain index since the last time you saw you. So blue is pain index, red is best, and yellow is worst. Do you see any correlation with administration of the medication and a change in the pain index? No. It's just a shotgun thing. And then I put in chronologically where the increase in dose from 120 of those immediate release to 240, and from 240 to 672. You would expect to see, especially that huge increase in the dose, that there would be an effect in the pain index, and there was none. So the plaintiff was seeking 1.7 to 2.1 million based upon whether they were receiving brand, because the Opana was only available at the time in brand. And I made an argument that, okay, if you are going to give these medications, why would you give this brand name drug? Why not give opiates that have generics available at a lot cheaper cost? So my opinion was that the pain meds were excessive, the treatment had plateaued, that the patient should be slowly weaned off the medications and alternative therapies initiated. And again, if you are going to give opiates, that you give the generics that are available. And I made this argument that oxycodone immediate release should be given instead of the Opana immediate release, and that you could move to fentanyl patches for the chronic pain instead of some of the longer release. The physician then added the fentanyl patch to the already existing extended release of the Opana. The lawyer told me that, I almost fell out of my chair. My first question to ask was, is she still alive? Because they started with a 100 microgram patch that comes in 12.5, 25, 20, 12.5, 25, 50, 75, and 100. They immediately jumped to the biggest patch. You could cause respiratory depression and death alone from just that fentanyl patch. I've had cases where, if we have enough time, I'll show you, they found a woman who was literally leaning against her bed, dead with a fentanyl patch on. Shouldn't the doctor, well, we'll keep going. So the question was, shouldn't the doctor lose his license? This was the judge's opinion. So the plaintiff, the lawyer for the woman who got in a car accident made the decision that it would be a judge trial and not a jury trial. So the judge's opinion, that it was reviewed by me and concluded, the prescribing physician reviewed my opinion and concluded that it was nonsensical, unethical, and dangerous. I was in the courtroom when he was testifying. The lawyer asked me to be there. I'm paid by the day, so I'm doing whatever they want me to do. So it was up in it was a local trial up in Augusta, and very stressful. They were building the new courtroom and driving the piles. Every 10 seconds, wham, wham. And I'm in the courtroom like you are on the sides, and this guy's up there testifying and basically calling me a moron for the whole testimony. So then I testify for the hour and 45 minutes. And a lot of the testimony of the opposing counsel revolved around, you're a pharmacist, he's a physician. Shouldn't you trust the physician? And I made the argument, no, I have the legal responsibility as a pharmacist to be that second set of eyes, and that if there's something amiss, I'm legally obligated to try to correct that. What I was surprised at is the pharmacists that were filling these prescriptions never called the doctor and said, you know, hey, what's going on? I mean, there are ways of doing that. You don't need to be combative. You can call them up and ask questions. You know, do you really want to increase this dose from 120 to 240, from 240 to 672, and to ask why? And you do have the right to refuse filling that prescription. So the rest of it was in my favor, and that the judge agreed that the patient should be weaned off the medications, and the verdict went down from $2.1 million to $122,000 to basically wean her off that, get her into the program, and then pay for the other therapies that were talked about. I think it's worthwhile, especially with this case, to talk about the things that you should be alerted to for diversion. So when I charted out the initial pain meds for the immediate release, if you're doing the sustained release correctly, the patient should not be picking up the immediate release on a regular basis. And if you need to, you then increase the sustained release forms, and therefore you decrease the amount of breakthrough pain and the amount of immediate release that they're taking. So if you have a chronic pain patient that's well managed and the pain medications are working, this is what should take place. And when I initially looked at the prescription record, that's what was happening. It was very intermittent refills. But at a certain point, especially after these big jumps, she was picking up that immediate release almost to the day every month. So at the end, that means she was taking 672 immediate release tablets a month. The street value for most of these opiates is $1 a milligram. That one prescription was worth $6,720 a month. So obviously a huge flag for diversion. Teenagers in the household, which she had, a spouse in the household with chronic pain, the husband had knee pain, that requesting the brand name, she wasn't doing that because the prescriber was obviously, I don't know if that took place, but the prescriber was writing for something that didn't have a generic available at the time. And why is that? Brand name generic. Why is that a red flag? Worth more on the streets, the brand names. And the people that abuse this know exactly what they're looking at. Okay, this is brand, this is generic. The ability to continue work while on high doses of opioids for chronic pain. She had a desk job that if she had this hip pain, because there was no imaging that showed any deformation in the pain, any deformation in the structure, so there was nothing in the bone or muscle that they could image that would suggest that she had a reason for the chronic pain. She also refused to be assessed by an independent physician. She drove like 45 minutes to a different physician that was hired by the lawyer who was hired by the insurance company, and she said, no, I'm in too much pain, I don't want you to assess me. And then absence of drug screens and opiate pain management agreement that wasn't being followed. There was no contract in place. And then there weren't drug screens that were done periodically. Another case, 75-year-old, oh, before I say that, any questions with that case? No? Another one, 75-year-old post-leukemic patient. The pharmacist dispensed immediate release on 2 separate occasions instead of the sustained release. The patient called the pharmacy after the first mistake, and the pharmacist told the technician to tell the client they are from a different manufacturer. What should have been done differently to prevent this error? Our pharmacy students should be able to answer this.
Should have the pharmacist speak to the patient directly?
Correct. Have the pharmacist speak to the patient directly. If you're calling up a pharmacy and you have this type of question, don't let a technician answer that question. Politely say, no, thank you, but I need to speak to the pharmacist for this. This is considered under the scope of practice, and you cannot have technicians answer these type of questions. And even worse, it was caught by the physician. So again, if you're a healthcare professional out there and a patient, you think a patient may be experiencing adverse effects from a misfill, you should chase that down. You should immediately assume, pharmacists are people too, and they're filling hundreds of thousands of prescriptions a year. You know, if you're a pharmacist and you make mistakes 0.1% of the time, you are a terrible pharmacist, if you just do the math. But mistakes are made, you should try to chase those down and make sure everything is appropriate. For example, with this case, there's software now that if you have a tablet and you don't know what it is, or you might think that it was misfilled, each tablet has a unique identifier. You can then call up a pharmacy, give them what that identifier is, they can put it into software and they can tell you exactly what that tablet is. This was the one with the fentanyl intoxication. So this person, diabetes, hypertension, COPD, chronic back pain, possible muscular dystrophy, again found dead at home, leaning against her bed. And the cause of death was cardiomegaly and poorly controlled diabetes, but a contributory factor was fentanyl intoxication. So fentanyl is a very powerful synthetic opiate. And in my mind, it's given way too frequently, especially now. I'm obviously biased, because half the cases I do are opiate cases, and half of the opiate cases are fentanyl cases. Patient after patient with either death or respiratory depression. And part of the problem is the pharmacokinetics. So if pharmacology is what the drug does to the body, pharmacokinetics is what the body does to the drug. And the metabolism of this can be very variable. So it can take 20 to 72 hours to get to that peak levels. And it's additive. So you have to be really careful when you're increasing the dose of fentanyl patches. And they should only be on fentanyl patches if they're already opiate tolerant at levels of 60 milligrams of morphine a day, 30 milligrams of oxycodone a day, or 8 milligrams of hydromorphone a day for a week or longer. You can give the lower doses, the 12.5 and 25, but I would argue against that as well. And the CDC guidelines talk about that you should not immediately start, or even in the beginning of therapy, you should be giving immediate release pain medications, not extended release pain medications. And you can also have a speed of delivery. So it's a very small clear patch that's normally given on the upper arm or the upper back. It's so small and clear that most nurses draw something on it, their initials or something, so they can find it. This person had put it in their sacral region. So you want to be careful with heating pads, electric blankets, tanning, sunbathing, saunas, hot tubs, heated water baths, and also any sort of oils or lotions can speed the delivery. And the other thing you have to be careful of is renal or hepatic impairment, being metabolized in the liver and excreted by the kidneys. If somebody has diminished function, you have to then back off on the dose. And on autopsy, she had, which is kind of hard to say that a physician would have picked that up, but she did have signs of both decreased renal and liver function. And again, the oils and lotions, alcohol shouldn't be given because it can speed the delivery. And the other thing is she had COPD. So you have to be very careful with people who have decreased respiratory function, asthmatics, people with emphysema, chronic bronchitis. That's the chronic bronchitis and emphysema are the umbrella for COPD. These people are going to be much more susceptible to respiratory depression. Patients 4 and 5, one was a cerebral palsy patient and another one had minor surgical procedure, and they were being given injections of fentanyl for pain management and became unresponsive due to respiratory depression, both of them in the hospital. How do you think you correct that? What's the simple thing that you can do, or hospitals should do, to correct when somebody is on an opiate in the hospital? Pardon me? Well, they did. They gave the naloxone. But prior to that, but to make sure you're getting in the room quickly to give the naloxone. Because one of the patients had minor surgery, the husband's in the room, he gets hungry, goes down to the hospital cafeteria, comes back up, and she's not breathing. Monitor it. Very simple, oxygen saturation and the thing to monitor respiration. I don't know why that doesn't take place in every hospital, why you don't have attached to the prescription order an order to monitor oxygen saturation and respiratory rate, so that an alarm goes off at the nursing station, and if they have to give the Narcan, the naloxone, they're in there quickly to give it. Because she then experienced cognitive difficulties for months. It remains to be seen if she's going to have permanent cognitive difficulties. This patient, 80 years old, had been taking intermittent, I think it was Vicodin, but was nowhere near the level to be considered opiate tolerant. And they did give the 25 microgram, not the 50 or 75 or 100 that the guidelines require, but she's 80 years old. And you went from intermittent sort of PRN Vicodin to then 25 micrograms of fentanyl. And then they actually started at 12.5, and then they went to the 25 and then went to the 50, and she became unresponsive. They had to intubate her and put in a feeding tube. They were able to take out the intubation, but then she had the feeding tube for another 3 years until she passed away from something else. I'll skip over this one. Horrible story with a 17-year-old that died from overdose, fentanyl patches. A friend had stuck 2 of them on that were stolen from a pharmacy. They were also drinking whiskey and doing bong hits and smoking pot, and he never woke up. I'll skip this one too. So as a pharmacist / pharmacologist, obviously my role is expertise in pharmacology, pharmacokinetics, and pharmacy practice, and that's what takes place when you testify. In the beginning, the lawyer who hires you asks you several questions about your background, and then the judge decides whether to vet you and to vet you for a particular thing. So I've been vetted in court cases for both the practice of pharmacy and as a pharmacologist. And I review the medical records, prescription refill patterns, overprescribing, diversion, abuse, and then I use databases and primary journal articles and guidelines to then determine what the standard of practice is. And that's a very good opportunity for you, especially if you feel like, I'm in this practice and I'm really busy. Go to the guidelines. The guidelines, that's what they do. They assemble a panel of experts. They go through all the studies related to that topic, summarize it for you, and make recommendations. And if you're using those guidelines and those recommendations and something happens, you have a much better defense than if you don't keep up with the recent guidelines. And then obviously I, again, help prepare attorneys for depositions and trials. I am telling them what kind of questions they should ask at depositions or trials, or anticipating what the opposing counsel is going to ask. So lessons learned, again, mistakes are avoidable and happen during that transition of care, or when healthcare professionals are overwhelmed taking care of too many patients. And that's what you have to decide. Your employer is going to try to make you, or hopefully employers don't do this, but in a lot of situations, employers are trying to maximize the profits and keep the practice open and operating. It's up to you as an individual healthcare professional to figure out in that environment how many people I can take care of safely and then push back. This happens in pharmacy. For me, working a 12-hour day, I could fill 250 prescriptions by myself, stressed, but still feel pretty good that I was doing it. Above that number, it's just too much. Advocate, we talked about for electronic medical records. Pharmacist verification that takes place in Maine Med. Every single prescription order that's generated is verified by a pharmacist. I'm confident that that orders for the 75 milligrams of morphine in 73 minutes would have not been given in Maine Med, because you would have had a pharmacist that would have stopped and called the floor and said, no, that you shouldn't be doing this. Again, document errors and use the data to implement solutions. And then when you make a mistake, don't just make excuses. You know, it's part of your profession. You need to square up your shoulders, look that person in the eye, describe what took place honestly, and then describe how you're going to implement procedures to fix that mistake. Most people, in my experience, don't want to go through a lawsuit. And usually they're just looking for compensation for what took place. You know, they went to the hospital and incurred $3,000 worth of costs associated with that mistake. They're looking for that $3,000 to pay for that mistake. Where it escalates is the lawyers come in and they tell everybody to not talk and that type of thing. But these cases take place over years. Most of these patients don't want to go through the painful, laborious process of a lawsuit that's going to take 3 or 4 years to get their money back. And a lot of that money then goes to the lawyers, especially the plaintiff lawyers, who usually don't take a fee. They take, if they get a settlement, they take out the operating costs to try that, to pay people like me, and then they get 30 to 40% of the settlement. And then lastly, again, reach out, talk to each other. You're going to produce the best patient outcomes, and you're going to prevent mistakes from happening. The last thing you want is to see me across the court testifying against you because you didn't talk to each other. Purchase individual malpractice insurance, especially for pharmacists, compared to the coverage you get, is dirt cheap. Read and understand the laws, rules, and regulations, and reach out. A lot of people say, well, I don't want to do that. I don't want to call my board and ask a question because that will send up a signal and they'll look at me. No, it's the other way around. The board is there to protect the community. It's not there to protect you. It's there to protect patients and the population in general. Reach out to them and you'll find that they'll help to educate you, especially if it's interpretation of a regulation or a law. Because a lot of times, you're working in a pharmacy, you get 3 pharmacists, and there's a prescription in there that's in the gray area. The 3 pharmacists are going to do 3 different things. Pick up the phone, call the board of pharmacy, call the pharmacy inspector, or whatever your board is, and ask that question. You know, better to do it beforehand than to have a case after. And then lastly, if you do have to appear before your professional board, bring a lawyer with you. Don't go into a board hearing without legal counsel, because it's basically a mini trial. And like the Board of Pharmacy in Maine has an assistant attorney general attached to that board. You go into that hearing, you're going to be grilled by that lawyer. And if you don't have legal counsel, then you're leaving it up to the fate. And you say, well, maybe it's really expensive to hire a lawyer. Well, it's a lot more expensive to have your license yanked and to go through the legal proceedings after that. Any questions? Okay, well, thank you for being attentive for the last 90 minutes.